practice question 4A. I'll be taking practice question 4A today. I am Uzoke Cyril. 4A says, 40-year-old man presented with upper abdominal pain radiating to the back. Patient coils up in fetal position whenever they experience the pain. He's known to have chronic dyspepsia. On examination, he was tachycardic, blood pressure of 90-60 millimeter of mercury, serum lipase of 1,200 units per liter, and serum amylase of 1,000 units per liter. Questions include, number one, mention 4 differential diagnoses. 2, what is the most likely diagnosis? 3, what is the most appropriate test to assess severity? 4, mention 5 causes of the diagnosis. 5, what are the complications? 6, what are the prognosis scoring indices in this disease? Do you know? You mentioned at least 5. 7, what is the link between gallstones and this disease? 8, what are the indications for draining a pancreatic pseudocyst? Question number 1, mention 4 differential diagnoses, and they include acute pancreatitis, peptic ulcer disease, pericarditis, atypical presentation of myocardial infarction, cholecystitis, cholelithiasis, dyspnea, dyspepsia. There's a rest down the slides. Question number 2, what is the most likely diagnosis? They include, my diagnosis is acute pancreatitis, given the upper abdominal pain radiating to the back, and the patient coils in fetal position to relieve this pain. Serum lipase that is elevated as high as 1,200 units per liter, and serum amylase that is elevated up to 1,000 units per liter, and associated symptoms of chronic dyspepsia. Question number 3, what's the most appropriate test to assess severity? They include the most of the imaging tests, including abdominal ultrasound, CT abdomen, MRI, and other serological tests, including C-reactive protein estimation that is as high as 150 milligrams per liter at 36 hours after admission into, it's also a predictor of severity. Question number 4, mention the causes of the diagnosis. They include what we acronym as I get smashed, I being idiopathic, accounting for 10 to 30% of the cases. G is for gallstones, and that's the commonest cause of this condition. E for ethanol, accounting for 35%. T for trauma, steroids, etc. The rest are on the slide. 5, what are the complications? They include acute complications being peritoneal fluid collection, shock, aka ARDS, DIC, hyperglycemia, hypercalcemia. Chronic complications including pancreatic necrosis, pancreatic pseudocyst formation, abscess formation, bleeding, thrombosis, bowel necrosis, fistula formation, recurrent edematous pancreatitis. 6, what are the prognosis scoring indices for this disease? Do you know? Mention at least 5. They include Atlanta classification of severity, Ransom score, Glasgow prognosis criteria in acute pancreatitis, Apache score, meaning acute physiology and chronic health evaluation, CT severity index in acute pancreatitis, bedside index of severity in acute pancreatitis, what we call BSAP. The rest are on the slides. 7, what is the link between gallstones and this disease? Gallstone is the commonest cause of acute pancreatitis, accounts for approximately 40% of the cases, seconded by alcohol that accounts for approximately 30 to 35% of the cases, then the idiopathic causes that are accounting for 10 to 30% of the cases. 8, what are the indications for draining a pancreatic pseudocyst? They include enlarging cyst with symptoms, cyst infection, cyst hemorrhage, cyst rupture, non-resolution of symptom or worsening of the symptoms. 9, synopsis of acute pancreatitis. The pancreas performs both exocrine and endocrine functions. The major cells in the pancreas include the acini cells, ductal cells, islet cells. Exopancreatic juice will include amylase, lipase, trypsin, chymotrypsin, carboxypeptidase. Endopancreatic juice will include the islet cell juices, including the alpha cell products such as glucagon, beta cells products, insulin, somatostatin, and pancreatic polypeptides. By way of definition, acute pancreatitis is self-perpetuating pancreatic enzyme-mediated autodigestion of pancreas, resulting in edema and fluid collection in the third space, including the peritoneum, retroperitoneal space, etc. Acute pancreatitis is a disorder that starts in the exocrine pancreas and associated with acini cell injury and local systemic inflammatory response. It could progress to chronic pancreatitis if there is massive pancreatic tissue damage or if the disease is recurrent. Etiology, as we have stated earlier, I get smashed, It could be classified as mild or severe disease. Mild cases usually account for the majority, up to 80% of the cases, and they're usually minimal organ failure and with an uneventful recovery, and respond well to supportive therapy. As against severe diseases account for just about 20% of the cases associated with multi-organ failure and local complications of the pancreatic tissue itself, resulting in necrosis, infection, pseudocyst formation, and may require ICU admissions. Regardless of the etiology, there is an intra-acinar activation of the trypsinogen to trypsin, which overwhelms the natural removal mechanisms. Trypsin further triggers the release of many active enzymes from the inactive forms in the zymogens, example, phospholipase, chymotrypsin elastase. Trypsin also activates coagulation complement fibrinolysis and kinase system. All this cause pancreatic autolysis. Molecular fragments resulting from these attract inflammatory cells, especially the neutrophils and macrophages. Neutrophils release superoxides and proteolytic enzymes. Macrophages release cytokines that further mediate local and systemic inflammation. Acute pancreatitis increases the risk of infection by compromising the gut barrier, leading to bacterial translocation from the gut lumen to the general circulation. In mild cases, there is edema and polymorphonuclear infiltration of the gland. In severe cases, there could be peripancreatic fat necrosis, pancreatic necrosis, and pancreatic hemorrhage. Pancreatic and peripancreatic abscesses and pancreatic pseudocysts could also complicate severe cases. Symptoms will include, as I stated earlier, it could be gradual or sudden in onset. The most common symptoms including severe epigastric pain right into the back and relieved by leaning forward, nausea, vomiting, diarrhea, loss of appetite, fever, and chills. Cardiovascular signs will include cardiovascular shock, abdominal tenderness, Gardner and rebound tenderness. Other signs of severe disease will include Gray Turner's sign, which is actually hemorrhagic discoloration of the flanks, Collins sign, which essentially hemorrhagic discoloration of the umbilicus. Laboratory investigation will include serum lipase, serum amylase, where we have at least 3 times the upper limit of normal, or up to 1,000 units per liter elevation in any of these enzymes. Reasons for false positive elevated serum amylase include salivary gland disease, intestinal obstruction, mesenteric ischemia, tubo-ovarian disease, and macroamylasemia. Elevated serum lipase is more specific for pancreas than amylase and remains elevated for up to 12 days after the insult. However, it is good to know that the degree of amylase or lipase elevation does not correlate with severe acute pancreatitis. Laboratory investigations will include full blood count, where we can have leukocytosis and neutrophilia. Serum electrolyte and creatinine may show electrolyte derangement. Blood urea nitrogen may be elevated. There may be hypocalcemia and elevated lactate dehydrogenase in biliary disease, especially in biliary disease, glycosuria, hyperglycemia in severe diseases, and triglycerides could be low. But it is good to note here that we should be aware of the pre-disease value. Ultrasound, we may use this to look for the causes such as biliary, in cases of biliary stones. Others include the other imaging tests, as I stated earlier on, abdominal CT, MRI, to look for severity and for equally the complications. Genetic studies are important in a recurrent pancreatitis, acute pancreatitis. Abdominal X-ray is equally good to look for complications, and erect chest X-ray is important
1 minute left.
All right, to eliminate other close differentials. American College of Gastroenterology diagnostic criteria states that diagnosis requires at least 2 or 3 of the following criteria: abdominal pain consistent with acute pancreatitis, such as our patient had; serum amylase and lipase greater than 3 times the upper limit of normal; characteristic finding on abdominal imaging, as I've stated earlier; and CT with contrast or MRI should be reserved for severe cases. Severity scoring system are very important because this helps to determine the management criteria of this patient. However, several multi-parameter scoring systems have been proposed, and several single-parameter biological markers have also been proposed. These are Apache score, physiologic, and laboratory conditions. The These are other severity scoring systems. These are other severity scoring systems. Good to note is that single parameter biomarkers of severity will include tissue necrotic factor alpha elevation, interleukin 6, 8, 10, polymorphonuclear elastase, C-reactive protein greater than 150 nanogram per ml at 48 hours, procalcitonin and PCV greater or equal to 47% are equally of negative predictive value. Management will include, we determine the severity, mild cases managed in the general ward, severe cases in ICU, and in principles of management will include the resuscitation, observing our ABC of management. Fasting of this patient may be necessary, and pain control is very important. Early detection of complications is important, and prophylactic broad spectrum antibiotics is still controversial. However, we know that with sepsis, the mortality increases to 40%. Identification of patients that may require ERCP may be important, and adequate nutritional support is important. IV support is very, we should be aggressive here with monitoring of central venous pressure may be necessary, pain control, and nutrition. We should commence oral nutrition as early as possible, except there is a case of gut failure. Total parenteral nutrition should be avoided as much as possible. IV antibiotics is needed when when sepsis is established. Surgery is needed when there is cholelithiasis and there is a CT establishing complications such as necrosis. Overall, mortality is 10 to 15%, and patients with biliary pancreatitis tend to have worse mortality than alcoholic causes. Thank you very much.
Thank you so much, Dr. Cyril Uzoke, for that brilliant presentation. Your efforts is highly appreciated. Okay, so the floor is open to questions and contributions. Okay, so while we wait for questions and contributions, just to add on to what's you presented. Okay, there was a question on what is the relationship between the gallstone and the disease, the pathology itself, that's pancreatitis itself. Okay, so basically, what actually happens is that, we have the common bile duct. The common bile duct is a combination of the pancreatic duct and the hepatic duct. So we know that bile normally is secreted from the liver and then from the gallbladder. It passes through from the liver and the gallbladder through the hepatic duct. So now when we now have this gallstone, what happens is that the gallstone goes to occlude the common bile duct. I initially said that the common bile duct is a combination of the pancreatic duct and the hepatic duct. So when we now have a stone around the common bile duct, what happens is that the pancreatic juice, which is the exocrine secretion that is supposed to be released and then taken into the duodenum, is then taken backwards because of the occlusion from the gallstone. So what happens is that this exocrine secretion will now start causing auto-digestion or autolysis of the pancreatic cells. So that will now bring about pancreatitis. So that's the relationship between the gallstone with the pancreatitis. So once you have a gallstone in the common bile duct, what happens is that there's a backflow of those pancreatic juice, and there's now what auto-digestion from those pancreatic juice on the pancreatic cells that will lead to pancreatitis. So that's the relationship with the gallstone with pancreatitis. Thank you so much, Dr. Uzoke. Okay, so
good morning. Let me just fine-tune. Sorry, dear. Good morning. Let me just fine-tune that's the ending of what you said. What happens is that trypsinogen activates the pancreatic enzymes, and that happens in the duodenum. So because gallstone occludes the common bile duct, there's now premature activation of the pancreatic enzymes while they are still in the pancreatic duct, the main pancreatic duct. So that is what causes the acute pancreatitis and then leads to the autodigestion. So there's activation of the enzymes, which is not supposed to happen within the pancreas. So that's what you feel to see. So that's, I've just wanted to correct that. Thank you.
All right. Thank you so much, Chief Kara. Thank you so much. I appreciate it. All right. So going into the chat room, Dr. Abimbola is saying thank you for an excellent presentation. Dr. Rita is also saying thank you so much for a beautiful presentation. So I'm not seeing any electronic hand up at the moment. I don't know if any gastroenterologists can actually make, that's a participant, can actually make contribution to what Dr. Cyril Uzoki has just presented. Any gastroenterologist in the house to add on? Okay, so all right, in the absence of questions and contributions from the participants, I want to hand over to our Chief Christabel. Thank you so much, Dr. Uzoki.
Oh, thank you so much, Dr. Siri. That was wonderful. Thank you. Thank you, Chief Cookie. Thank you so much, ma. Faith and Yusuf, these are a group I used to disturb. Faith Agbaje, Yusuf, Rahim, didn't hear your voice. That is fine. Don't know if Chief Cookie have any more comments. Our Chief Gastroenterologist. Chief Cookie, any more comments?
Sorry, Chief, I'm in transit. Good morning, ma. Good morning, everybody.
It's fine. I remember. It's fine. It's fine.
Okay, yeah. Well done. Well done to the presenter. Thank you so much. I think we covered all the bases. I think this is something we've treated before. So the diagnosis was gotten as the acute pancreatitis, and then all the differentials, which we should think of the structures that are surrounding the pancreas that will be found in the epigastric or the upper part of the abdomen, and also in the chest. So we should remember that. And I think the other question where they said the diagnostic, the imaging modality of choice, this is a CT scan, not an ultrasound scan. If you are talking of acute pancreatitis, because the pancreas is the retroperitoneal organ, so, and usually you have the transverse colon overlying it, so it's going to blur the vision for the sonographer, so you won't appreciate the pancreas very well, except maybe in chronic pancreatitis where there can be calcium deposits and all. There's some calcifications and you may see it, but usually in the acute setting, you will not appreciate the pancreas very well. The only reason we want to do a scan is because if gallstone is the cause of the acute pancreatitis, which is a very common cause, it's the imaging modality for it is an ultrasound scan, but a CT scan can also show it. But if it is just for acute pancreatitis, then a CT scan is the imaging of choice. Then we have other imagings which you didn't mention, the endoscopic ultrasound scan. It's not available in the country, but it's also important to note, and that we also use for that. Then, of course, the scoring systems and knowing the parameters in the scoring system, and then to note that those scoring systems are usually they are not a one-off thing. So you take them at presentation and then 48 hours later, because they help in prognosticating, and then you'll be able to classify the patient into mild, moderate, or severe, as the case may be. And then understanding that in managing these patients, it's a teamwork approach. Apart from the gastroenterologist, you also require ICU or high dependency units, in severe cases. And then, of course, the surgeons also come in. And then you also need the nutritionist, and what have you. And then even the interventional radiologists in managing this patient, because one of the major issues here, apart from the electrolyte imbalance, the severe the SARS that comes from the inflammatory response, that they have, they can also have other complications with the necrosis, like all those pseudocysts, pancreatic necrosis. There are later complications, but immediately you can even have an acute kidney injury, occurring, and that can also lead to mortality in these patients. So you need to be preemptive. So fluid resuscitation is very important, and then pain management, because it's a very painful procedure. It's a very painful disease or disorder, because the celiac trunk, which has a lot of nerve, the nerve plexus is just around the pancreas, so the pain is excruciating. So you have to be able to manage pain appropriately in these patients, and then of course, because of the dehydration, if not properly managed, the patient can go into shock. And so these are all the things that can lead to death. So you need to be on top of your game in managing these patients. And then of course, when the patients recover, if the acute pancreatitis was due to a gallstone, then the says that before the patient is discharged, you must offer the patient a cholecystectomy, because that patient will come back again with acute pancreatitis. So you must remove the gallbladder in that admission. That's what the guideline says. Then if it is due to gallstone, alcohol, any of the other causes, you need to counsel the patient, send to behavioral psychologists, to help the patient to recover from alcohol addiction. And then if it is due to maybe hypercalcemia, or even lipid disorders and all that, you manage appropriately. So that's what I wanted to add. Thank you very much.
Thank you, Chief. Thank you.
Thank you, Ma. Thank you so much, Ma. I appreciate you, Ma. Thank you. Dr. Stereo, I don't know if any of our teachers have any more comment before we move on. Okay, thank you. Thank you. Dr. Stereo, thank you so much. We appreciate your time and the slide you've got available for us. Please, all the corrections, you just add it to the slide. I know the one Chief said about CT scan and abdominal scan. So please, necessary corrections, add it to the slide, and as soon as possible, forward it to the page so that those new for the exam will have access to it. Thank you so much. Dr. Kalamama, you can continue.
Okay, thank you, Chief. Okay, so Chief Cyril, please, can you unshare?
Yes, let me try and do that.
Thank you. Thank you so much. We appreciate it. Okay, so the next presenter is going to be Dr. Yusuf Rahim. He'll be taking us on practice question 5E.
Thank you.
Okay.
Okay. Hello, good morning.
Yeah, good morning. So you have 10 minutes to take your presentation. Okay. After questions to come on. Thank you.
Okay, is my slide visible now, please?
Yes, we are seeing it.
Yeah, good morning, our teachers, senior colleagues and colleagues. I will be taking the practice question 5A. My name is Rahim Yusuf. So the question is, a 74-year-old woman with heart failure, bilateral severe osteoarthritis, dyspepsia, who had a fall in the bathroom, has been on ibuprofen, 400 milligrams BD, omeprazole 40 milligrams daily, spironolactone 50 milligrams, and captopril 10 milligrams daily, and amiloride and hydrochlorothiazide. So she presents to the hospital due to severe pain. The radiograph done was normal. The BP was 115/70. Her creatinine was 2.3 milligrams per day. Estimated glomerular filtration rate was 20 ml per minute per 1.73 meters squared. PCV was 28%, potassium was 5.5. So she was also prescribed IV morphine, 20 milligrams 6 hourly, and was discharged home on oral morphine, 20 milligrams 6 hourly, alongside her regular medications. So she presented again 2 days later with altered consciousness, vomiting, abdominal distension, and constricted pupils. So the first question, the question that follows: 1, what is the diagnosis for the second presentation? 2, list 4 clinical features to support the diagnosis. 3, what are indications and predisposing factors for the first presentation? Number 4, how will you manage this patient? 5, how do you prevent this from reoccurring? Then what are the reasons for the second presentation? The 7th question, they criticize the medication the patient is on. And then lastly, they say we should discuss about geriatric medicine use. So for the first question, what you diagnose for the second presentation is opioid toxicity or opioid overdose. So that's the diagnosis for the second presentation of the patient. So what are the four clinical features in the history that support that diagnosis? One, she presented with total consciousness, vomiting, she has constricted pupils, and she also presented with abdominal distension. So these are the features in the history that support the diagnosis of opioid toxicity or overdose in the second presentation of the patient. The next question is what are the indications for the first presentation? So at the first presentation, she had history of fall, and that fall was also because she also had bilateral severe osteoarthritis. So these are the indications necessitating her first presentation. So what are the predisposing factors for the first presentation? That's one, because of her age. Likely elderly people are usually they're usually unstable, and also they usually have these geriatric giants, instability, mobility, cognitive impairment, and so on, all the eyes, including hypergenesis. So because of her age, two, she's anemic, her PCV was 28%. That may also predispose her to dizziness, and that may also contribute to why she fell at the first presentation. Then how will you manage this patient? Managing the opioid toxicity or opioid overdose is actually a medical emergency. ABC resuscitation is actually very important. We want to maintain a patent airways. We want to ensure that she's breathing well. Ensure that the tongue is not falling backward. You can actually insert an oropharyngeal airway. We want to ensure circulation by actually securing a wide bore IV access. They want to ensure that the airway is clear. We want to suction PRN if there's any secretion, remove dentures. Then also I want to give her supplemental oxygen. Now, management of opioid toxicity, management of airway is actually very key in the management of opioid toxicity because they usually come with respiratory depression and with also with hypoxemia. So airway management is really very important. Also, sometimes we also need to actually give them mechanical ventilation with endotracheal intubation. Also necessary in management of their airway. They want to give the antidote, that is IV naloxone, which is the antidote for opioids. I want to give a milligram of 0.4 to 1 milligram. And that we actually give it every 1 to 3 minutes until when the opioid effects are usually reversed. And that's the when patient is having normal respiration and also patients also regain their consciousness. Usually we don't want to exceed 10 milligrams in total dose given in 24 hours. And however, once we are unable to reverse the opioid toxicity after giving a maximum dose of 10 milligrams per hour, usually it is said that we should reconsider that diagnosis. Or sometimes patients may actually take the opioids together with other sedative, benzodiazepine, and other psychoactive substances. There may be co-injection of these drugs. That may be responsible for why patient is not being reversed. But for those that are presenting with strictly opioid toxicity, usually before giving up to that maximum dose, usually they recover. They want to reassess the patient usually after each naloxone dose. Then also from the history given to patient also came with hyperkalemia, potassium of 5.5. So we want to correct the hyperkalemia, want to stabilize the myocardium by giving IV calcium gluconate. We want to give 25 grams of glucose with 10 units of soluble insulin. You can also give furosemide. You can give nebulized salbutamol to correct the hyperkalemia in the patient. They want to discontinue the morphine and also use alternative. After patient has also recovered, patient's education is actually very key. Then we have to counsel the patient, then find out why the patient took overdose of the medication. If it's an error from the doctors or the healthcare professional, we want to also correct that. So patient education is also key part of the management of this patient. Now, how do we prevent this from reoccurring? One, we want to use drugs like buprenorphine or co-administration of naloxone together with opioids. It's actually been found that sometimes to prevent overdose, you can prescribe naloxone together with some other opioids. And the one that has actually been approved in USA, the buprenorphine, which is actually a synthetic opioid. You can actually prescribe it together with naloxone. That actually reduces the risk of overdose in those that are actually chronically taking morphine. The use of initial small doses, which can be titrated up gradually. This patient, the index patient, was actually given a very large amount of large doses of morphine frequently. So we want to give them small doses which can be titrated up gradually. And that is known as start low, a low dose, and go slow. Start low and go slow. That's actually what is actually advocated for someone that is starting opioids newly. Then also want to use country-specific guidelines, which recommends opioid risk assessment to want to assess patients, because some patients are actually at risk of developing opioid toxicity. Like this index patient has renal impairment. It's actually a risk factor for development of opioid toxicity. So want to assess the patient for risk of development for overdose. There should be a written agreement between the prescriber and as well as the patient as a dose to be taken. Also the frequent urine drug testing to mitigate the risk of toxicity and overdose. Also want to monitor the prescription monitoring by frequent appointments for small number of doses. Want to give them, sometimes you can even be giving them daily dosing of potent opioids for those that are management for chronic pain. Then patient education is actually very important than counseling. You have to tell them the risk, the type of drug they are taking, the risk involved in overdose, and also we have to tell them the effect of that drug. But when you have counseled patients very well, they are not likely to take overdose of the drug, either intentionally or unintentionally. Then what are the reasons for the second presentation? One, patient has renal impairment. Opioids are generally being excreted through the kidneys. So patient has likely have CKD. So that's one of the risk factors. There's reduced excretion of the drug, and that's one of the risk factors for the second presentation in that patient. The opioids overdosing due to severe pain. Patient was given 20 milligrams 6 hourly. That's actually a very large dose, and it was so that overdosing was also one of the risk factors for second presentation. Then short dosing interval. The drug was given 6 hourly. So these are the likely reasons for the second presentation. So how do you, the next question is how we should criticize the medication the patient was placed on. One patient has been on spironolactone, which is potassium sparing diuretic. It may worsen potassium retention in that patient, and that patient is having CKD. So that may lead to hyperkalemia. Patient is also on captopril too, as we know, it's also a potassium can also cause hyperkalemia too, and may also worsen hyperkalemia in the patient as well. The patient is also on amyloid and HCT. They are actually not very good diuretics in CKD, and that's actually because of due to poor expression of HCT in CKD patients, and that will actually cause lead to some side effects that may worsen the CKD. They may have electrolyte derangement, they may have hyperuricemia, may have hyperlipidemia, and these are risk factors that may worsen or that may encourage progression of CKD. Patients also on ibuprofen, 400 milligrams BD, and we know NSAIDs generally they may cause afferent arterial vasoconstriction. Then high dose morphine, patients should have also receive a lowest dose considering the renal function of the patient. So these are the criticisms for the medication the patient is on. Then for geriatric medicine use, as you know, elderly constitute a growing population. Let's mute this person, please. So the elderly constitute a growing world population. There are about 200 million people over 60 years. They have multiple chronic as well as multiple degenerative diseases, and this actually predisposes them to frequent hospital visits as well as increased consumption of medication. They are particularly susceptible to adverse drug events, a lot of drug interaction due to polypharmacy. The knowledge about appropriate prescription clinical pharmacology of medication is actually very essential. Then elderly too, they have some physiological changes due to they have reduced functional reserve, as well as reduced ability to adapt to changes in their system. The renal elimination and hepatic metabolism of drugs generally are decreased in the elderly. They also have decreased gastric acid secretion, which also predisposes them to a lot of GI infections. So just brief about opioid toxicity. And opioids, they are actually naturally occurring substances derived from opium poppy plant, widely used primarily to control severe pain. While opioids, on the other hand, they are the semi-synthetic or the synthetic forms of opioids. For the etiology, usually opioid overdose generally can be either unintentional overdoses in elderly. Sometimes some of them they may have the dementia, and they may be unintentional. They may take the drug overdose unintentionally. They may be intentional overdose, maybe because of suicidal attempt. They can have complication of substance abuse, those that are abusing drugs, then therapeutic drug error. Like in this index case, it's actually the healthcare personnel that actually made that error. So these are like the causes of opioid overdose generally. Then the risk of toxicity generally return to use after sedation for those that have stopped taking for a very long time. By the time they are coming back, they have to start very small dose. So they are at risk of developing toxicity. Those that are taking escalating drug, increasing the drug. Those that have some background medical illnesses, HIV, liver and kidney disease. Liver, the drugs are actually being metabolized by the liver and being excreted by the kidney. So liver impairment, kidney failures, and they are actually risk factor for development of toxicity. Those that combine opioids with other sedative, alcohol, or other psychoactive substances, they also at risk of developing toxicity. Male gender is a risk factor. The younger age and white non-Hispanic race are also risk factor based on studies. Then for the pathophysiology, activation of the opioid receptor results in inhibition of synaptic neurotransmission in the central nervous system as well as in the peripheral nervous system. Opioids generally decrease the perception of pain rather than eliminate or reduce the painful stimulus. So that's what they do. They actually reduce perception of pain. And these opioids bind to some receptors in the brain, mu receptor, kappa, delta, as well as sigma receptors. So these are the various manifestation in binding to various receptors. The kappa receptors are the one that mediate the meiosis. It is also important to know that there are clinical trials seen in overdose of opioids, and that's usually meiosis, that's pinpoint pupils. They have respiratory depression as well as CNS depression. These are the clinical trials of opioid toxicity. The respiratory depression is the most specific signs that we see in opioid toxicity, meaning that sometimes they may have mydriasis, that's dilation of the pupils, and sometimes their level of consciousness may not be totally depressed. So respiratory depression is the most specific symptom, and in their management, airway management too happens to the most important way by which we manage them, after followed by giving them the antidote. Then the history usually is obtained from others. Many of the times they may present in comatose patients, they may present in comatose. Sometimes you may see pills, empty bottle, needle syringes around the patient or other drug paraphernalia. Then the symptoms we see generally nausea, vomiting, lethargy, utter level of consciousness, euphoria, abdominal distension. Then the signs include coma, lethargy, meiosis, drowsiness. They may also have seizures as well. Then they may also have some psychiatric features, including euphoria, depression, hallucinations, and so on and so forth. These are the differential diagnoses in them. How do we evaluate the patient? Always consider opioid overdose or toxicity in any lethargic patient with no other identifiable cause. Patients who abuse opioids also tend to use other illicit drugs like cocaine and benzodiazepines, and they may have suspicions of co-ingestion to be raised when the usual clinical signs are not related to that of the clinical signs of opioids. So you have to consider the other substances being injected together, being ingested together. Also, sometimes by the time you're also giving the naloxone up to the maximum dose, which there's no reversal, you have to also consider co-ingestion of other agents. Laboratory investigation, want to do toxicology for urine and blood. The urine is the most specific. Random blood sugar, hypoglycemia may complicate the problem. Arterial blood gases, as we said, you have respiratory depression with hypoxemia. Electrolyte and creatinine liver function test, liver derangement, CKD may worsen excretion of opioids and may predispose to toxicity. And creatine kinase level, they may have rhabdomyolysis from seizures, ECG because of cardiotoxicity. Chest X-ray, they may have acute lung injury, especially heroin is a specific opioid that may cause acute lung injury. Then abdominal X-ray for those that have body. But how do we manage them? As I said earlier, I've mentioned this earlier, ABC of resuscitation. Airway management is very key. Then you give them naloxone, which is the opioid of choice, the antidote of choice for their management. They are also importantly in the management is after reversal of toxicity, patient should be admitted for observation for about 12 to 24 hours. Then other measures that we can use apart from this naloxone, which is the of choice, is actually the use of activated charcoal for GI decontamination. Actually, it's also because, and it has been found that because it causes it lowers gastric emptying, so the opioid tends to remain within the stomach for a very long time. And that's why use of activated charcoal is actually also has been found to be useful in their management. However, if patient is unconscious, we have to ensure that the gag reflex is intact before we give activated charcoal. That sometimes if naloxone is not available, we can actually use that for patient that is conscious or patient that has intact gag reflex. We can also use bowel irrigation for the removal of drug packets in body packers, and that's in drug peddlers that swallow drugs. Buprenorphine can also be used as other measures that we can use to prevent or manage toxicity. How do we prevent them? Use of buprenorphine and naloxone combination. I've mentioned this earlier. The initial small doses, that is start low and go slow. Use of country-specific recommendation, precision monitoring, and this sort of patient education is very important. So thank you for listening. I acknowledge Dr. Igba P.K. Brown for using the slide with few modifications. Thank you for listening.
Thank you so much, Dr. Yusuf Rahim, for that excellent presentation. Your efforts is well appreciated. Okay, so it's time for questions and contributions from the participants. Okay, while we wait for questions and contributions, all right, so there was a question that was asked about how do you prevent opioid toxicity. Just to add to what you just stated, we can actually make policies whereby opioids should not be given over the counter, meaning that for it to be given to a patient, it has to be prescribed by a doctor. So I think that will help to curb opioid toxicity in patients generally. That can also help to prevent opioid toxicity. There has to be doctor's prescription before they can get it. Thank you so much, Dr. Rahim, for that beautiful presentation. All right.
Thank you.
Okay, so going into the chat room, Dr. Blessing Amadi is saying, thank you for a beautiful presentation. Dr. Musa Joseph is saying, thank you for the lucid presentation. Dr. Felix Aninangi is saying, excellent presentation. Another risk factor for falls in the elderly is polypharmacy. Yeah, thank you so much for your comments. So I'm not seeing any electronic hand up. Okay, yeah, Dr. Chineme, you can please have the floor. Thank you.
Good morning, my teachers and colleagues. Thank you for the presentation. It was nice. Just to add to it, even when the opioids are being prescribed, they still need to be monitored, because most times, most of our patients, even after that period, they may get addicted to it and keep going back to refill, even when not needed. So even after prescription, they should be monitored, even when our patients are on it. Thank you.
Thank you.
Thank you so much, Dr. Chineme, for that beautiful input. Thank you, we appreciate. Okay, I'm not seeing any other electronic hand up. Okay, so going back into the chat room, someone is saying, okay, Dr. Lawrence Adeyeye is saying, thank you for the presentation. Does opioid cause meiosis or mydriasis? And any other antidotes apart from naloxone? You got the question right, Dr.
Yes, I got it. I got
right.
it. Thank you very much. Can I respond now?
Yes, you can.
Yes. Opioids actually cause meiosis. And I mentioned that the triad, the clinical triad is that when you have meiosis, CNS depression, as well as respiratory depression. But the respiratory depression is the most specific sign that we can actually be certain that there is opioid toxicity. In some individuals, they may not have meiosis, they may have midpoint pupils or even mydriasis sometimes. And the CNS depression also varies from individual to individual, and also depends on the amount ingested. But respiratory depression, once there's toxicity, respiratory depression is the most specific. Meiosis is what is seen. Sometimes you may see mydriasis. Thank you. Then the antidote of choice is naloxone. Naloxone.
All right. Okay. Is there any other one aside naloxone?
For antidote, well, I'm not aware of any. For antidote.
Okay, thank you. Thank you.
Thank
All
you.
right, so Dr. Abim Bola is saying thank you for the presentation. Dr. Yaya Mohammed is saying thank you for the lucid presentation. Another possible cause of fall in this patient is arrhythmias from heart failure. Thank you, Dr. Yaya Mohammed, for your contribution. Dr. Akinwumi Ojo is saying, is there a need to educate the prescriber in this question? Is there a need to educate the prescriber in this question? Dr. Rahim?
Yes, actually, there's a need because the cause of toxicity in this index patient is actually an error. It's actually an iatrogenic cause because the error is actually from the prescriber, from the healthcare worker that actually prescribed that 20 milligrams 6 hourly for someone for the first time. So there's actually a need to also educate the prescriber as well. Because maybe the prescriber is not aware and is also not aware of a lot of background health conditions of that patient. being a new patient with background CKD, heart failure, and elderly patients and so on. So I think thank you for that add-on. There's a need to also educate because that's actually the cause of the toxicity from this patient. The error is not from the patient, it was from the prescriber.
Yeah, thank you. Okay, due to polypharmacy. Thank you so much. Thank you so much, everyone who has contributed via the chat room and also via talking. So in the absence of contributions and questions, I would like to hand over to our Chief Christabel. Thank you once more, Dr. Rahim.
Thank you. Thank you.
Okay, thank you. Thank you so much, Dr. Kalamama. Thank you, Dr. Yusuf Rahim. Congratulations.
Thank you,
you've always been eloquent. You're already speaking like a fellow. Congratulations. I love the way you spoke, so nice, so confidently, so eloquent, so fluid. Thank you, thank you, thank you. Congratulations, congratulations, congratulations. So I don't know if our teachers have any comments. Comments from our teachers. Okay. So, Yusuf, our teachers are okay. They're impressed with your presentation. The candidate too. Everybody's happy. So we appreciate you once again.
Thank you, ma'am.
We appreciate you for your time. Thank you so much. Thank you. Dr. Kalamama. So let me quickly